welcome to today's episode. I'm so glad you all are here, as today we will be going over ADHD, youth mental health, and we're striving to understand and support young individuals with ADHD. But before I introduce our amazing guest, I want to share a memory from my childhood. Back when I was in 4th grade, there was a student in my class named Noah. He was known to most people as the person that blurted out in class, always flicked his pencil around and created noise. And at one point, he irritated my teacher so much she put his desk in the corner. However, I befriended him because I saw the kindness that he displayed and the amazing facial expressions he always had and the energy he always brought during recess. I once asked him, why is he so disruptive in class? And he said, I'm trying. I really am. But however, my TV is like my brain is like a TV that cannot be turned off. At the time, I didn't have the words to understand this, but I did understand the feel of it. Him feeling like he's not seen and he's not heard. And this memory inspired this episode, as today I want to address how young individuals with ADHD should develop their self-esteem and they should have the support they need to feel seen and heard. Now I want to introduce our distinguished guest, Dr. Shashank Joshi. Thank you for joining us today, Dr. Shashank Joshi.
Oh, my pleasure.
Dr. Joshi is a professor of psychiatry, behavioral sciences, pediatrics, and education. He serves as the director of Stanford's triple board residency program and leads key school mental health initiatives at Lucille Packard Children's Hospital. He also plays an important role in supporting student well-being across Stanford as Senior Associate Vice Provost for academic well-being. Dr. Joshi's work bridges clinical care, cultural awareness, school-based mental health, and youth identity, making him the perfect voice for today's conversation on ADHD, stigma, comorbidity, and culturally diverse experiences. Dr. Joshi, thank you for coming on the podcast today. Words cannot describe how much thankful I am for you to take time out of your busy schedule to join me today. So,
my pleasure. It's really delightful to be with someone like yourself who's so interested in this topic so early and someone who's willing to share their story, and also you've already had so much impact by all the work you've done so far. So my pleasure to be here with you.
For my first question on school mental health and whole child support, you spent years helping schools build environments where students can thrive. How can schools reimagine their support for students who might be struggling with ADHD and focus in ways that honor the whole child, not just their symptoms, but their strengths, cultures, and stories?
Well, you mentioned something really interesting there. As I understand the question, you didn't just describe children who have a diagnosis. You're describing children who may have not yet had a diagnosis or who may not actually fully have the syndrome of ADHD, but they are struggling with attention or focus. They may be struggling for other reasons. There may be anxiety, there may be trauma, they may be preoccupied with other things going on in their lives. And all of these things get in the way of being able to be their best in school. And so the school districts that we've gotten to work with over the last 25 years or so, mostly in Northern California, but other places in the country, I think, that do it well, they already understand that they are teaching children, they're teaching students. They're not merely teaching subject matter. Our students are not bots, nor are we as teachers. So everything we do is relational in the classroom. It's starting in kindergarten, going through postgraduate work, undergraduate work, everything in between. And so I think that schools don't have to reimagine anything. What they have to do is, in some cases, they simply have to get back to a very simple premise. If this were my child, or, some of our teachers are very young, they don't have their own children yet. If this were my niece or nephew, how would I want this teacher, how would I want this school site, this school psychologist, this counselor to be first understanding who my child is, what their strengths are, what they're good at, how they engage, what their interests are, before I focus on the things they're struggling with. And lastly, before I ever conceptualize what's wrong with this child, because I think that's where we start to make some assumptions and some mistakes. If we begin with that deficit model, what's wrong with this child? Let's begin with, who is this child? What is their story? What are they good at? What are they interested in? Let's build on those strengths. And let's not ignore that the child is struggling compared to, if I'm the teacher, compared to my other students, this child is struggling. Let's try to understand first what they're good at, and compared to other kids, I see them struggling. Let's try to understand that better. And once we can do that, then I think we will really be able to not only understand the whole picture, but then make recommendations and make interventions that hopefully will have a good shot of improving this child's experience in school, getting them access to the curriculum or to the classroom if they're a younger child, and taking the next step forward.
Amazing answer, Dr. Joshi. To elaborate on the part you said about their involvement in school, the 2023 American Academic of Pediatrics Clinical Report on School Mental Health stressed that, and they said that academic supports were best help the child when it was associated with belonging, adult connectiveness, and emotional security. What I mean by belonging is clubs in school, like athletic clubs and curricular clubs and outside of school clubs, because these help you feel like you're part of a group, you're part of a team. This gives you a sense of belonging, and it can increase your self-esteem and self-confidence. Also, adult connectedness and emotional security, they're both about expressing yourself to the trusted adults in your life. You don't need to hide how you feel about yourself to them, because when you express yourself to them, you're basically freeing yourself of the burden of having to deal with that yourself internally.
Absolutely agree. And we know that some children and some teens have an easier time of doing that than others. And if you are part of something organized, like a club, like theater, like a sports team, like the paper, like the school media outlet, whatever it might be, if you are doing something that connects with other peers on campus, that can be extraordinary. And that can move us from a place of feeling like we need to fit in. Like, if I need to fit in, I need to be like you, Kirtan. But if I truly belong, I simply need to be who I am. And we know that belongingness, which has been measured empirically, not only helps our students' mental health and well-being, being who you are, wherever you are. And it typically means being part of some kind of an affiliate group, a club, an organization, or a school campus where you can be accepted and celebrated for who you are. But also, we know that a sense of belonging can be a protective factor from mental health conditions becoming severe mental illnesses and even leading to crises. And so that sense of belonging you talked about, I think, is so important.
Yes, definitely. For our second question about cultural stigma and understanding ADHD, your work often explores how cultural shapes the way families talk about mental health. How might immigrant or minority families interpret behaviors associated with ADHD differently, and how can educators or clinicians open doors instead of putting up walls?
The first thing we always think of child psychiatry as family psychiatry. And that's what we do in the Stanford program. In pediatrics, we think about mental health as part of overall health. In our child psychiatry program, general psychiatry, or other psychiatry programs, we always think about our clients or patients in the context of their families. And so when it comes to immigrant families in the US, we know there are between 65 and 70 million children and teens going to public school. 25 to 30% of those young people are immigrants or children of immigrants. And depending on what part of the country you live in, for example, in Northern California, Many of our districts have 60 or 70% immigrant diaspora from all over the world, where the child might be born and raised here, but they are born of immigrant parents who did not go to middle or high school here. And so they have a very different experience of what the social expectations are for going to school and what the academic expectations are, and how do you bring those two together. And so I think when it comes to behaviors associated with ADHD, what I've seen in my practice and what we've seen over the years, and I do think it's getting better. I think more discussion leads to less stigma, but we still have the challenge where when we see behaviors that are part of the ADHD condition, including distractibility, inattention, focus problems, forgetfulness, disorganization. Some families will attribute this to laziness or lack of effort.
Oh, yes.
And we know that the opposite is typically true, where the child who has ADHD, and it's typically diagnosed in childhood before middle school, but sometimes the diagnoses come late. We might be making diagnoses in high school or college or in the workplace after high school. But typically we see this in children second, third, fourth grade, when the work starts to get more difficult, when more independence is required, when children begin reading chapter books and have to summarize and really have to pay attention to the main idea and not get drowned in the details. Well, that's very difficult for children with ADHD who have a lot of noise, and what we're trying to help them with is to focus on the signal. Now, in classrooms that are structured with teachers who really understand the neuroscience of ADHD and what the implications are for the classroom and how to set up the classroom environment to really help these kids learn at their best, it's all doable. The challenge is if we simply say this child's not trying hard enough, they're too lazy, they just want to go and play video games, we're missing the point, which is think about this child as an individual, look at their strengths. They are interested in a lot of things. They be interested in everything. What we're trying to get them to focus on is the thing, right? Whether it's the chapter summary, whether it's the main idea in the book, whether it's the assignment. You did the assignment, you don't know where you put it. It's crumpled in the bottom of your backpack, right? So it's not through a lack of smarts. It's not through a lack of effort. It's that we don't see the same amount of development in areas of the brain in terms of neuroscience. And you know this, Kirtan, because of all the work you've done already learning about ADHD. If we don't have the same receptor density, if we don't have the same degree of development in those key areas involved with dopamine production and norepinephrine production, right? You'll see on neuroimaging studies and PET studies what the differences are in blood flow in those areas. And so what we can do is we can enhance those areas with behavioral strategies, with classroom strategies, with targeted medicine treatments to help those areas work more efficiently. And when we prescribe a psychostimulant, for example, it's not a sign of weakness. Some parents will see this as a failing on their part. No, it's my fault. We were not strict enough. We didn't push them hard enough. We didn't send them to enough Saturday school. This is really about the brain developing in its time, and it will get there eventually. And we have plenty of students at places like Stanford and UCSF and Santa Clara University here in our locale with diagnosis of ADHD who do very well academically and go on to professional careers that are meaningful to them. And they may need some assistance in structuring their work, structuring their day, structuring their schedules so that they can do their best work. And I liken it to the glasses that you're wearing and I'm wearing. Now, let me ask you, Kirtan, are you nearsighted or farsighted? In other words, is it hard for you to see distance things if you don't have your glasses on?
Yes, it is hard to see things in the distance.
Yeah, so for me, on my driver's license, I am required to wear glasses because I'm nearsighted. So I can't drive without my glasses. I could probably get through my day without my glasses. It would be hard. I wouldn't be very efficient. I would be distracted. I'd probably get a headache. I do this with parents because they're often coming in with their glasses. So I'll take my glasses off. They'll take their glasses off. I'll say, just humor me for a moment. What's it like for you first thing in the morning without your glasses or without your contacts? And they'll say, well, it's blurry. I bump my head. I can't see anything. And then what happens when you put your glasses on? Okay, things become much more clear. Now I can get through my day. Well, my glasses don't do my work for me. It doesn't sign my charts for me. It does not review the candidates' files for me, right? My glasses allow me to do my best work in those domains. And that's how we think about interventions, whether they be in the classroom or be at home if they're behavioral or if they're medication related. It's to help the young person to do their best work. And that is how we want any family to understand the brain basis of ADHD and other mental health conditions. So not simply focusing on immigrant families, although the question asks, maybe there are some families we work with where they may not have the same language for mental health conditions, least of which would include ADHD, right? They just might call them, I had cousins growing up in India who were just called naughty, they just don't listen. And what we've learned is ADHD occurs across cultures, and ADHD can be not only managed in the classroom and treated, but also children and adults with ADHD are often highly intelligent and have numerous strengths. We just need to find ways to uncover them. And so whenever we are with families, we always want to reassure them that what we're talking about here is a condition that is common, that can be treated successfully. And we've had a lot of great results because we have a lot of science to show what's helpful.
Yes, what an amazing answer, Dr. Joshi. I want to elaborate on the part you said where in India, people in your village, people didn't interpret it the way that more educated people would. They would think it was naughty. They would think it wasn't acceptable. And that actually ties into the research I did leading up to this episode. In the Pediatrics Journal in the 2020 article, Morgan et al. Actually found that Black, Hispanic, and Asian children are actually significantly less diagnosed for ADHD than their white peers, despite showing the exact same symptoms. And this is actually tied to them having less help-seeking behavior, which actually makes sense.
And I wonder, I haven't read that study, but I wonder if it's the help seeking that is measured on behalf of the child or the teen, or is it the help seeking that's measured on behalf of the parent? Like, who is not seeking help? The child may be asking the parent for help. The parent may not believe there is any need for help.
It was actually measured by the parent asking for help.
Yeah. Yep. And we've seen that data in Asian diaspora, in big national data sets as well, looking at immigrants who tend not to seek help for their own mental health struggles. And that's not just true for South Asians, but in that sample, they looked at immigrants from South Asia, from China, and from the Philippines, and saw very similar trends in terms of the underreporting of mental health conditions, even though we know from big data sets that immigrants struggle with many of the same mental health issues that their say non-immigrant American counterparts do, and in some cases in more severe ways, they just struggle in silence because they may not have a language for the mental health struggles that they are suffering from.
Yes, for our third question about ADHD and its correlation to emotional pain, many young people facing attention challenges are also dealing with anxiety, depression, or heavy stress. From your lens, how can families and schools recognize when ADHD-like behaviors are actually signals of deeper emotional needs and respond with compassion and clarity?
Yeah, so I think the idea that you're presenting in that really thoughtful question is attention, distractibility, and forgetfulness can be a sign of many different things. We might think about ADHD as a common condition, especially if it runs in families, if a sibling was affected. But if we're doing a really thoughtful, thorough workup, we get a really good history. We talk to the family members. We really try to get that school history over time. If it's a brand new presentation and the child is in middle school, and this is the first time that they are presenting with symptoms of inattention, distractibility, forgetfulness, and concentration problems, ADHD would not be the first thing on my bingo card. I would be thinking about the why now aspect of this presentation, because again, we think of this as a developmentally relevant condition that gets better over time. We know that cerebral volumes can be 4 to 5% smaller in children with ADHD compared to, for example, same-aged peers or even siblings who don't have the condition. Their cerebral volume will get there. It may just not get there until their early 20s instead of their late teens. And so a lot of this has to do with neurobiology and morphology of brain development. A lot of it has to do with receptor density in development. And many of the same areas of the brain that affect ADHD, dorsolateral prefrontal cortex, and some of the other striatal areas also affect other conditions of childhood. And you probably know this from your research, Kirtan, that most diagnoses that we make as psychiatrists in adulthood had their roots in childhood. And ADHD is probably the best example of that. We typically see signs in childhood, and we really have to be very thoughtful and thorough in making sure that we have thought about the other conditions or the other environmental stressors that may be leading to these symptoms of inattention, distractibility, forgetfulness, whatever the ADHD presentation might be. Sometimes people can have both. They may have ADHD plus anxiety or depression symptoms, but attention and focus problems, concentration issues, sleep issues, those are what we would call sensitive for a lot of different things, but specific for very few, because they cross over into so many different diagnostic categories. So I like to think of attention problems or concentration problems as just that. They're causing problems for a child's life. Let's figure out if this is a variant of normal, if this is a problem, or if this actually is a disorder that needs further treatment.
Thank you for your insight, Dr. Joshi. Can you tell me any specific scenarios that you have seen that reduce stress and anxiety in young people with ADHD?
Absolutely. I can give you an example from a classroom that I was just in last month with one of my residents. That classroom was set up so skillfully by a teacher in third grade who, this is a teacher who has a reputation for really understanding how to make the classroom very, very friendly for a neurodivergent group of kids in her class. You know, she's like 25, 30 kids in her classroom. Probably 5 or 6 of them are dealing with something. ADHD, autism spectrum, separation anxiety, something. And she's got a group of 20 or so kids who are actually neurotypical and doing pretty well. So how does she set that classroom up? Well, she has activities. Kids are always moving. They do not have to be silent, and we don't ever see or experience children should be seen and not heard from. These kids have, the kids who need to be moving around, they tend to have places to go in the back. They have a supplemental room where they can have fidgets and things that they can use, because for them, learning is very kinetic. Learning is very active. Learning is hands-on. For others who need a quiet classroom, those kids are seated at a table where their peers are quiet so they don't get distracted. And sometimes you have the kids who are having attention and focus problems seated next to kids who don't mind helping a peer. So it's a very intentional way of setting up a classroom, understanding that our learners are always diverse, whether they have a diagnosis or not. And teachers who are very attuned to their learners are able to set up their classrooms and maintain their instructional pacing in a way that makes sense for all the kids. Now, I will say in this classroom, she's a very experienced teacher, and she has a teacher's aide in the classroom, and that helps significantly because then that teacher's aide can work with groups of students, whether that be the neurotypical or so to give the teacher the time to work with the kids who have a few more specific hands-on supervision needs or vice versa. But Again, I think that's a matter of curricular planning, not only for which kids are coming into that third grade classroom, but also who is the teacher who is set up best to be able to meet the needs of those diverse types of students. Because there may be other teachers who are way more used to having a certain kind of student and maybe not having the flexibility in their curricular approach, and they may have other strengths, as a teacher, but they may not be the best fit for this group of kids that you and I are talking about right now.
Amazing answer, Dr. Joshi. For our fourth question about medication, meaning, and cultural sensitivity, your upcoming book looks at the relational and ethical dimensions of prescribing for diverse youth. When it comes to ADHD medications, what conversations do you believe are essential, especially with families for whom mental health treatment may carry cultural stigma?
Yeah, I'd bring it back to the example that I mentioned before with the glasses, where we're trying to help parents understand that these mental health and behavioral conditions that we diagnose are because your child is presenting with a lot of strengths. They do a lot of things very well, and they struggle with other areas because they learn differently compared to how the other kids are learning. And so what we want to do is understand their learning styles and then provide them with tools to be able to get access the curriculum and do their best work, because we know they're capable. And in some cases, they are highly capable. They just are having trouble with this particular type of problem or curriculum or classroom setup. And so the way that we try and approach the idea of any treatment, whether it's modification of the classroom curriculum, setting up, say, a 504 plan with modifications in the general classroom, or even the idea of having an IEP and maybe spending some time in a resource classroom, even that can be stigmatizing. So we're always getting back to the core value of putting the child first and foremost at the center of our conversations, and trying to help that child to be able to apply their strengths, because we know that all children have strengths, and our job as educators and the trusted adults in a child's life is to figure out what those strengths are and to help this child be able to, learn how to think in a way that is consistent with what their strengths are, while not ignoring the places where they have challenge. The places where they have challenge, for example, in the case with a child with ADHD, combined type, which is the most common, is that the use of medication, when done properly, can be extraordinary in helping that child to be able to focus, to be able to concentrate, and actually do their academic work and access the curriculum and be able to be on par, if not better than other kids in the classroom, but for the way their brain is learning. And again, this is backed by the science. When we look at children and teens and adults who are diagnosed with ADHD, and we look at the trajectory of their brains, and we look at blood flow in the basal ganglia, for example, when we look at dopamine receptor density, we can see differences between those who have the condition and those who don't. We see differences in when we prescribe medication and what happens and how children and adults respond. And the clinical correlates of that in the classroom are, let's say a family is reluctant to begin medicine right away. We understand that. We must first start with the things we know are helpful in terms of structuring a classroom, in terms of de-chunking materials so it's not overwhelming, in terms of strategic placement of the desk for a distracted child with ADHD, placing them next to quiet peers, next to peers who might be willing to help them, perhaps next to the teacher, and then every month changing their setting for where they are in the classroom in order to make sure that they have a slightly new microenvironment, right? So that they don't just acclimate to one. Now, in some cases, you want to keep them in the same place because it's successful. So we don't want to fix what ain't broken. But that requires some flexibility on behalf of the child and also on behalf of the parent to say, we've done this diagnosis. We believe he has this condition called ADHD. explaining what it is, being able to answer questions, referring them to reputable websites, and then being able to be open to the idea that the family may be very reluctant at first to try medicine because there's a lot of stigma associated with it. So then we go with whatever else we know could be helpful to them, short of the medicine, but we talk about all of it as an intervention to help your child get access to the curriculum and show their best work, because we know your child has lots of strengths. And so sometimes really those two principles, focusing on the strengths, finding out how we're going to be able to help them to show their best work, and conceptualizing this as a brain condition. And this is why I always wear my silver ribbon pin whenever I'm wearing a jacket, because people ask me, what is that cool pin? I've never seen the silver ribbon. I've seen all the other ribbons. What does silver mean? And we talk about this as a destigmatization strategy, because it leads to a conversation, and that is how we defeat stigma, one conversation at a time. And so share your story. Talk about your own lived experience or those of your children or a friend. This silver ribbon pin is about the idea that mental health conditions live in the brain. Mental health conditions are brain conditions. And I know someone with a brain condition, and whomever it is, it's my friend, my son, my parent, whatever it is, myself. So that's why you try and approach this in different ways. You're simply opening the door to the conversation. There are very few ADHD emergencies where we have to start medicine at the end of this visit. This is really about creating a shared understanding. So yes, the parents can learn from us what we think might be helpful, but most importantly for us as physicians to really understand the family story, what their concerns are, and what their hopes are. Because then when we make recommendations, we're in a much more familiar place to the family, instead of feeling like this is just a doc who pushes medicine and that's all he does. And that's the last thing we want to do as child psychiatrists.
For our fifth question about identity, belonging, and diagnosis, you spent much of your career helping young people shape healthy identities. How might an ADHD diagnosis affect a young person's sense of self, for better or for worse? And what can adults do to ensure that this label becomes a lens of understanding, not a weight they carry?
I think it gets back to starting with strengths and understanding that this is not an ADHD student, an ADHD child, an ADHD adult. This is a person who has this condition called ADHD, right? Keeping it person-centered and really helping parents understand that that sense of self is crucially important, because then we can all focus on the strengths so that we can deal with the challenges. But if we're only dealing with the challenges, then we are not going to be able to make progress on a child's education, a child's healthcare overall. And so I think those are going to be very important considerations. I think the second piece might be that we want to think about treatment not as a crutch, but we want to think about it as a tool. So the tool is there to help people to do their best work. It's not a crutch to be dependent on for one's whole life. Now, it's also true that in many cases, we see this sort of in a rule of thirds, where a third of the patients we see get better, and a third might actually get worse. So that means somewhere between a half to 2/3 are going to have reasonable symptoms that are going to require our attention. They may or may not need medicine. They may or may not need the same dose, but many do really benefit from continued intervention. And what we see is we don't see addiction in children with ADHD to their stimulant medicine, because what we're really doing is we're trying to address some of the receptor profile changes that are needed in order to help the child do their best work. So we still revisit the idea of medicine at the first non-stress time. If we say like 9 months of health, right, of best functioning possible, and then maybe in the spring we think about, okay, do we really need to be continuing to treat over the summer? Perhaps the answer is yes, because the young person has a job or they're in summer school or they need to sustain a matter of with the family and with the patient, to see what might be best. So I do think that the diagnosis itself is an opportunity to have conversations. And this diagnosis happens to be one aspect of this person's life. It does not define the person. And so if we think about it in that way and we put it in context, we're better able to open the doors to conversation and help the child and the family, for that reason, for that matter, feel seen and heard, so they don't have to feel stigmatized. So placing any diagnosis in the context of this is a child, this is a young person, this is a young adult with a full life and a lot of strengths. And they're also dealing with some challenges. And we understand those challenges to be part of this condition called ADHD. And here's what we can do. Here's what the science says we can do to support this person, to treat the symptoms, and to really give them the best shot to have the most choices about what they want to do. But in order to do that, we have to really unlearn some of the lessons we might have learned from our parents or our parents' parents about things like, in the old country, we just worked our way through it. We didn't have this condition. This is an American creation, or this is a Western European creation. In fact, this condition has been around since the 1920s. It's been written about since the 1920s. What we've come to understand better is the neuroscience of ADHD, of receptor profiles, of brain development, of evidence-based practices that can help children and young people really understand this condition so they can learn strategies to deal with some of the problems while not ignoring some of the strengths that they have by virtue of having a wonderful brain that perhaps just learns in a different way.
Excellent answer, Dr. Joshi. In my research for this episode, I also came across something that's actually very reminiscent of what you just said. It came from a 2022 qualitative study in the Child Care Health and Development Journal, and it found that teens experience shame when the adults in their lives focus solely on their ADHD alone. They don't focus on their personality or anything else when they're trying to help them. They just view them as ADHD child, so we're going to do the classic tips. But it was found in another study, the 2023 study in the Journal of Adolescent Health. They found that a positive identity development ensued when they allowed them to embrace their neurodivergence and incorporate the positive aspects of it into their lives. And they focused on more than just helping them. They focused on implementing what they were interested in into their solutions. So that helped them develop their self-esteem and self-confidence.
Well, beyond simply surviving, but actually thriving, right? So I think the work that you're doing, Kirtan, to get the word out early with support of parents who have helped you to tell your story and also interview people who've had experience in the medical world is exactly what we need to be doing. Using your platform with all the followers you have to get the word out and talk about this as, giving some light to the idea that a mental health condition is like a physical health condition. It's all health. And what we need to be doing as the trusted adults is helping our young people get healthy, whether that's mental health or physical health. And I think that allows us to have more conversations, that allows us to decrease the stigma, and that allows our youth to truly feel supported.
Dr. Joshi, I appreciate your amazing contribution to this podcast. I think this episode has brought something very new to the series. It helped us understand how we can, how we've always touched on how we can support others in our community, but this explained how it's not only about helping them cope with their ADHD, it's also about helping them learn about themselves beyond just their ADHD, their personality, their interests, and implementing that into their self-regulation. So I appreciate that.
Well, thank you, Kirtan, and best wishes in your continued work.
As I always like to do, I like to close off my conversations and interviews with a quote. And today I have a piece of poetry from Gujarati Indian poet Narsi Mehta. I'm going to sing it as it's part of an amazing bhajan. Vaishnava jana to tene kahiye je peet parai jaan re. This means a true human is one who understands the pain of others. This lesson of empathy is very reminiscent of what we talked about in today's podcast episode. Having empathy for others when not everyone will see the good in everyone. You need to be the one that sees the kindness or the energy that someone may bring despite their ADHD. I encourage you all to add something new to your community and teach everyone around you that someone who has ADHD should not be identified, as Dr. Joshi says, as an ADHD kid. They should be identified as someone who has these struggles and happens to have ADHD. Dr. Joshi, you have illuminated the ways we can support young people in our communities with more compassion and cultural insight. Thank you all for listening, and I would appreciate if you all could like and subscribe to the channel, as this would mean everything to me, as it would share the channel around the world, which is ultimately the goal of this podcast. Thank you, Dr. Joshi, and I'll see you on the next one. Goodbye.
Bye.